Well, thank you everyone for attending this webinar today. My name is Mark Klein. I am a medical hematologist-oncologist. I'm an associate professor at the University of Minnesota. I'm also a staff oncologist at the Minneapolis VA Medical Center. We will talk about many veteran issues today, and this is not specifically a VA-sponsored program. So we will start off with our educational objectives for this program. Around this program, we first will summarize our current best practice approaches for management of head and neck cancer patients within VHA, which is the Veterans Health Administration, the Department of Defense, MHS, and our objectives today will also be important even for non-veterans as well. Once we get through our front matter, we'll talk about biomarkers, the potential for their use in prognosis prediction and overall treatment selection and optimization. We'll discuss current studies going on, specifically around de-escalation and immunotherapy, and we'll talk about trials that are planned. And then we'll finish up with some special slides on immunotherapy, focused on the most recent data from the recent American Society of Clinical Oncology meeting that is FDA approved but has yet to be published, and current data on second-line therapy use in head and neck cancer patients. So our outline today, we've already done our introduction. We'll focus on epidemiology at first, review some of the updated epidemiology studies and findings recently. We'll then go to biomarkers, followed by treatment. Due to the fact that there is so much information out there and so many studies going on, we have to focus it on some select areas. So we will focus on de-escalation therapies, specifically strategies around de-escalation, immunotherapy, conclusion. On this slide, we have a sagittal section of a head and neck cancer focus area. Specifically, we have the anatomy around head and neck cancers here. As a reminder, head and neck cancers predominantly start at the lip and then end where the larynx and the trachea come together. Thus, when we're talking about head and neck cancers, we're mostly focused on the following subsites. So the lips, then the oral cavity. The oral cavity transitions into the pharynx at the transition where there is the soft palate and the hard palate. Then behind the oral cavity, the pharynx is divided into the nasopharynx, oropharynx, hypopharynx, and then finally the larynx. There are other head and neck cancers in this area too that we won't talk about today, specifically salivary gland tumors, nasal cavities, and paranasal sinuses. Those are important, but the bulk of the information that's coming out is focused on the sites that we just discussed. While there are also many different subtypes of head and neck cancers, we will be focusing on squamous cell carcinomas, as over 90% of head and neck cancers are squamous cell carcinomas that originate out of the sites that we've just discussed. So head and neck cancer epidemiology. More recently, the National Cancer Institute has updated epidemiology around head and neck cancer. Projections for 2019 in the United States lead to estimates for approximately 53,000 new head and neck cancer patients being diagnosed with head and neck cancer within 2019. When you take a look at the entire cancer population and all the new diagnoses that are occurring in 2019, approximately 3% of all these patients will have head and neck cancer. That translates into 11.3 patients per 100,000 people being diagnosed with head and neck cancer. However, when we take a look specifically at the veteran population, 6.3% of veterans that are diagnosed with head cancer in 2019 would be expected to have head and neck cancer. Thus, you can see that the veterans have a specific burden around head and neck cancer due to the increased incidence compared to the population outside of VA. When we take a look at all of the patients in 2019 diagnosed with head and neck cancer, and then it is estimated that around a little over 10,000 patients will die from their head and neck cancer, meaning that approximately 20% of all the patients diagnosed will die, and approximately 80% will survive their cancer throughout the year. We move on to the next part on other aspects of epidemiology. There has been a male predominance compared to female incidence in this disease that has been persistent. Just under 3 males will be diagnosed for every female. It continues to be a diagnosis of patients over the age of 50, even despite the increasing incidence of human papillomavirus-associated cancers. Cancers in the head and neck continue to be predominantly locally advanced diseases. Distant metastases continue to be rare, with approximately 10% or less of the cases being associated with metastases. If we note that the graphs to the right of our epidemiologic findings here, when we take a look at the 5-year survival of head and neck cancer patients, it continues to increase. Right now, approximately 65.3% of all head and neck cancer patients will survive 5 years. This is a number that continues to climb and points to two particularly important aspects. One is that there are still a number of patients that are dying from the disease, but also that it's not as dire a disease as it is anticipated to be. Thus, continued efforts to continue to improve treatments in this is of paramount importance. Our next slide, we'll talk about risk factors. In the next set of slides, we'll talk about traditional chemical exposures, and we'll follow up with viral exposures. So in this particular slide, we'll focus on alcohol and tobacco. Prior to the advent of the discovery of human papillomavirus-associated head and neck cancers, alcohol and tobacco were the chemical exposures that were most commonly associated with head and neck cancers. And if we take a look at the top line, one particular study demonstrated that patients that drink quite heavily, over 10 drinks per day, have a 5-time increased risk of oral and pharyngeal cancers. This compares very similarly to those that are considered to be heavy smokers who smoke a pack a day or more. They have a 20-fold increased risk. When we combine drinking and tobacco use in people, the increase is synergistic, and we have a 50-fold increased risk of developing head and neck cancer. Even though these risks are in patients that have heavy use of smoking and alcohol use, those that have moderate or light use of these substances also have increased risk, but not quite as high as those that we just discussed. One thing that patients oftentimes will ask is, what's the point in stopping smoking or stopping drinking since they already have a poor prognosis or a significantly problematic cancer? However, data continues to show that cessation of smoking is very important for not only recurrence rates, because if you stop smoking, recurrence rates will drop at least 4 times, depending on the circumstances. And even a small amount of smoking with regard to the time frame can be useful. So say, for example, if you quit smoking for just 1 year, the risk will start to lower. And if you quit for a full 20 years, you approximate the risk of those who have never smoked. So stopping smoking is of critical importance, and it's one thing that as providers we need to remember to continue to ask these questions of our patients and continue to work with our partners to help them stop smoking at any point in the treatment process. The next risk factors we'll go to are viral. We just want to remind everyone that Epstein-Barr virus exposure is still thought to be a risk factor. Predominantly, it's around nasopharyngeal carcinomas. We won't get into nasopharyngeal carcinoma today. However, keep in mind that EBV virus titers have been utilized in some treatment strategies in following Epstein-Barr virus-associated tumors, so keep that in mind when you're treating nasopharyngeal carcinomas. Next, we'll focus a little bit on human papillomavirus-associated head and neck cancer. Around 2007 was when the association between human papillomavirus, which from now on we'll use the term HPV positive for those that have human papillomavirus positive cancer and HPV negative for those that don't. With regard to HPV-associated tumors, around 2007 is when we first recognized the association. This has become a significant potential biomarker for head and neck cancer and is the focus of the strategies around treatment modality adjustments moving forward. It's increasingly being recognized that HPV positive and HPV negative tumors are likely distinct clinical entities with regard to prognosis and potentially with regard to response to treatments. Approximately 60-80% of oropharyngeal carcinomas are positive for human papillomavirus. This number had been climbing for several years and more recently has plateaued right around this particular number. Of the HPV-associated cancers, oropharyngeal carcinoma has the strongest association with this virus. Oftentimes we see during our testing for HPV, which we'll get into a little bit, is that it's associated with an increased level of a protein called P16. And that is because it is a reflection of the cells responding to the HPV viral DNA. When HPV infects a particular cell, oncogenes called E6 and E7 get incorporated into the cell and cause a reflex increase of the protein called P16 as part of the cell's response. And we'll get into this in just a little bit later. One thing to keep in mind is that HPV-positive tumors have a much better prognosis than HPV-negative tumors, with 2-year survival rates across the board of 94% for HPV-positive and 58% for HPV-negative. We'll get into this more later because this is a major reason why newer treatment strategies are being devised to try to take advantage of this particular finding, with the goal being maintaining efficacy of treatment while dropping the toxicity as much as possible. So this leads us next into the challenges with veterans, and they'll become a little bit more evident further as we go on these couple of slides. Head and neck cancers are rather difficult cancer to treat. We oftentimes have a requirement for a lot of time and intense burden for visits and toxicity of the therapy. Head and neck cancer patients have very unique challenges. And this slide is where we'll transition over to talking about specific veteran challenges. Head and neck cancer patients oftentimes require quite intense therapies that involve many visits and a lot of toxicity. This gets compounded in veterans due to socioeconomic status issues, an average increased age compared to the non-veteran population, significant comorbidities, and higher exposure to other carcinogens and alcohol and tobacco. So this modifies their baseline risk for cancer incidence, but also is problematic regarding the treatment and ability to handle the toxicity of that treatment. Other specific needs for veterans include travel. Across the board, veterans tend to be much more rural in their location compared to non-veterans. The other thing is split care. By split care, we mean care being done at a VA hospital partially and care being done at a non-VA hospital. It's recognized that when care is split like that, there are specific challenges, and if not done optimally, will lead to decreased efficacy and problematic outcomes. And one example specifically is radiation oncology. Not all VA hospitals that treat cancer patients have radiation oncology on site, so it's important to have a good working relationship with the hospitals that have this capability. And one example of other issues regarding veterans' health challenges include the next slide here. Specific challenges also include lower median income. So veterans have challenges handling a lot of costs surrounding ancillary incident costs that we normally wouldn't have a problem with. Precision medicine is certainly gaining momentum within most of medicine, but specifically in oncology. However, head and neck cancer is one area where precision medicine has yet to gain a strong foothold. One of the reasons why has been some challenges around particular biomarkers for head and neck cancer. In this following section, we'll talk about why biomarkers have particular use in head and neck cancer, and we'll also talk about some of the challenges. People up to now have had some skepticism about precision medicine and the benefits for head and neck cancer, but I think overall the field as a whole is starting to transition over to this line of thinking. One of the main issues with cancers is the heterogeneity of the tumor. We can see patients with very similar clinical presentations, however, they have different responses to therapy or different prognoses up front with tumors that look almost exactly the same under the microscope. Thus, there are some strategies to try to figure out if we can use biomarkers or other molecular-based tests in order to better identify the prognosis for particular patients, to better risk stratify those patients. Examples include identifying patients that appear to be higher risk, like those that are smoking, but yet are still HPV positive. Thus, they're a patient population we would expect to have a better prognosis, but the smoking modifies that. Thus, stratifying patients based off molecular markers has a high potential to better stratify these patients for improved outcomes. So the following pathways tend to be named based off of the most common protein that's recognized from that pathway. So say, for example, EGFR. We tend to name pathways based off of EGFR for the EGFR pathway. Same thing would be for PI3 kinase, so the PI3 kinase pathway, the mTOR pathway, which is very closely related to the PI3 kinase pathway, the nuclear factor kappa B pathway, which is called the NF kappa B pathway, and the heat shock protein 90 pathway. So this is just an example of several pathways that all interact within the cells. So using this as a baseline to understand how we will delineate pathways and other mutations in these pathways, we'll subsequently go to HPV positive versus HPV negative tumors. Each type of tumor will have different sets of pathways that will be mutated. For example, in the HPV positive tumors, we tend to have pathways that are mutated in PI3 kinase, in FGFR3, which is fibroblast growth factor receptor type 3. In the HPV negative tumors, we tend to have slightly different pathways that are mutated. For example, P53 and related proteins, pathways involving mTOR, pathways involving CDKN2A, which is a major player in the cell cycle pathway, pathways in Notch. Ways to look at those pathways is to look at mutations. In the right part of the slide, you see a graph that is probably fairly familiar to many people. On the y-axis, we have the somatic mutation burden, which is the number of mutations per million bases or megabases. On the x-axis, we have the particular tumor type. Approximately one-third of the way from the right, we have head and neck cancer. And you can see in the slide to the right, the tumors to the right tend to have higher number of mutations per base pair. It's thought that tumors with higher number of mutations per base pair might be more amenable to immunotherapy, and that's borne out across many studies. So these findings tend to lead providers to design studies where immunotherapy is forming a base element of the treatment modality. So currently, there are some biomarkers that are being worked on right now. Some of those could be tissue-based, some of those could be liquid-based, and we'll talk about those in short order here. Currently, some of the markers that are being worked on head and neck cancer in tissues include P53. There's a lot of work looking at P53 mutations specifically in HPV-negative tumors. HPV-positive tumors include E6 and E7 viral proteins that we discussed before. There is increasing amounts of work being done around those to better identify subtle amounts of HPV involvement. This could be used for such things as monitoring for minimal residual disease. With regard to immunotherapy, tumor-infiltrating lymphocytes and expression of PD-L1 is emerging, and currently PD-L1 is very important as a biomarker in most patients getting immunotherapy, and tumor-infiltrating lymphocytes are starting to move in that direction. One thing to keep in mind is when we are testing for human papillomaviruses, there is no test that has FDA or other regulatory approval officially. However, most hospitals will use one of the following tests. We can either use P16 immunohistochemistry to look for the presence of P16, or we can look for human papillomavirus genomic presence via PCR, otherwise known as polymerase chain reaction, or something called in situ hybridization. Within oropharyngeal cancers, the correlation between P16 and PCR findings has been quite good, with the correlation rates being over 90%, so many labs will use that. However, many studies, it's important to keep in mind, will use the combination of both and will stratify patients based off of the relative presence of P16 and negative PCR and vice versa. Further evidence that supports the potential studies of these markers in the prognosis and prediction of therapy in head and neck cancer involves data that suggests that these biomarkers are associated with different prognoses. For example, on this slide, on the top we see overall and disease-free survival curves for patients that have testing for P53 in their tumors. So in the left upper quadrant, for overall survival in patients that have P53 abnormalities, we can see that the survival is much decreased for those with P53 mutations that are present versus those that are not. In the right, we see similar findings for patients with regard to disease-free survival. We see similar findings for the presence or absence of the gene that encodes for P16, which is CDKN2A. We find similar findings for Notch and similar findings for this gene called CCND1. Of note, CCND1 also encodes for cyclin D1, which is involved in the cell cycle and is very closely related to P53 and very closely related to P16. However, there have been challenges around tumor-based tissue biopsies, and so we're going to transition to the rationale for liquid biopsies right now. Current standards of care with regard to evaluation and treatment of head and neck cancers employs things that people are generally pretty used to dealing with regard to clinical practice. So clinical examination, which is not to be underestimated, and I use this as a reminder for really incorporating the use of ENT surgeons in ongoing treatment modalities, regardless of the modality. The use of ENT surgeons for good ongoing clinical examination can't be underestimated. We also tend to use a lot of imaging techniques, specifically PET-CTs is an area where that would be standard, MRI is a little bit less so, and then biopsy of tumors, usually at nodes or sometimes at the primary site. However, the issues with single-site biopsies of tissues has to do with the heterogeneity and sampling bias. So say, for example, with regard to sampling bias, we know that false negatives and false positives can occur, with false negatives being the bigger concern. Liquid biopsies potentially could be a modality to get around this. With regard to tumor heterogeneity, it's known in many studies that if we biopsy tumors and sample them over time, or even at the same time, and do repeated genomic testing on them, the genomic testing will be different even though we're biopsying the same tumor. So there's issues around that where liquid biopsy potentially might be able to be an ancillary or a complementary technique to get around this. The advantages to liquid biopsy is that they can be less invasive. So when we're talking about liquid biopsies, we're mostly talking about blood tests where we do some sort of genomic testing after we draw the blood. Other positives to liquid biopsies would be is they might be better for screening up front, and there's even a possibility for using saliva for some cancers. One thing is, though, is that liquid biopsies would be a big paradigm shift, and it would be important for educational processes to help get these out to the population in larger numbers. So this next slide, we're talking about typical liquid biopsy techniques. Liquid biopsies thus far in the research efforts have focused on circulating tumor cells or circulating tumor DNA. We'll focus next on circulating tumor DNA. Cancers grow fast and die fast. Thus, cancers are constantly dying, expelling the contents of the inside of the cancer cells into the bloodstream or other fluids on a constant basis. This forms the rationale for testing for circulating tumor, otherwise known as cell-free DNA. Thus, newer techniques are capitalizing on the sensitivities of these newer techniques in order to identify DNA at very small levels. Circulating tumor cells can be evaluated in a similar fashion. While these cells are intact, the testing modalities can also have similar benefits as the cell-free DNA. On this particular slide, we take a look at the application of tumor DNA in a hypothetical patient. So if we take a look at the x-axis, that's time in one particular patient. On the y-axis, we have the circulating tumor DNA with in a hypothetical patient in their plasma or their saliva. And there's no units on this particular graph, but the higher we go up the graph, it's postulated this would be the higher incidence or higher concentration of the particular DNA findings. So if we take a look at the different brackets here, the first bracket shows where we hypothetically could follow someone at risk for cancer. So we would be hopefully identifying patients that either are in a pre-malignant or early stage window where we possibly can intervene. If we miss someone at that particular stage, we can say we go to the top of the peak, and that would be where someone theoretically would be in a more advanced state. There would be some threshold that you would hit, and then you would do an intervention via some modality, and then the DNA theoretically would go down, and then you possibly could follow them over time. And there would be a threshold for no evidence of disease or recurrence. So we could see that it's possible that this could be a more sensitive technique than our current modalities with clinical exam or PET-CT findings. On the next slide here, we see other techniques under investigation. Some of those include exosomes or microvesicles. Exosomes are small microparticles around the 10 to 100 nanometer size that are membrane encased and contain proteins and DNA, RNA, and other things in the cells. So there you can think of them as kind of mini cells without the organelles. The data around exosomes and microvesicles is emerging, but not nearly as far along as circulating tumor DNA or circulating tumor cells. Tumor antigens would be such things as proteins on cell surfaces like PD-L1. That's not quite as far along. And then the last one would be cell-free coding and non-coding RNAs. Specifically, this would be where microRNAs would fit in. At this point, hopefully you've had a good introduction to some of the newer thinking around biomarkers and the epidemiology of head and neck cancers, and we'll transition over into therapy approaches. While there's a lot of emerging data on head and neck cancers, due to time constraints, we're going to focus on two of the areas that tend to have a lot of activity right now, specifically de-escalation and immunotherapy. So right now, this is an overview to remind everyone on treatment strategies in head and neck cancer. The site of disease, the stage of the disease, and the actual pathology currently guides treatment choices. So at this point, the modalities that we would use for head and neck cancers include surgery, radiation, systemic agents, and we'll include chemotherapy and other targeted agents like EGFR targeting, such as cetuximab, together in that group, and then immunotherapy. These modalities could include 1, 2, 3, or now potentially 4 of those modalities altogether. Understanding the tumor biology is very important in treatment now. Specifically, HPV-positive tumors versus negative tumors. That predominantly right now is for prognosis, not for prediction. So what I mean by that is that we know that people with HPV-positive tumors will oftentimes have better survival, live longer, but we don't know that if we give a particular therapy that will have the ensuing findings. We just know that they do better on that particular treatment plan, and some of the strategies here is to figure out if we can change the treatment plans and maintain those same good efficacy. So we'll focus on these studies coming up, looking to see if we can potentially personalize the treatment approach to various cancer patients. So in this next slide here, we're talking about the goals of therapy. Most head and neck cancer patients present as local or locally advanced head and neck cancers. I would argue that cure is still the goal in most of these patients because they have such high response rates and so many patients do survive, as we saw in our epidemiology slides earlier. We also want to have local regional control. We want to keep the cancer away in the local area. We want to also prevent metastases. We want to have distant control. Another major area is organ preservation. Patients oftentimes may have to undergo quite morbid surgeries where they might have to have part of their tongue removed or their larynx removed, and so the goals of therapies would be to try to preserve those organs. Other thing we want to do is minimize complications during our therapy. For example, head and neck cancer patients that undergo chemotherapy and radiation oftentimes have long-term issues, and we'd like to minimize that. Along with that, certainly with all these goes quality of life. One of our main goals of cancer treatment is to keep the quality of life as high as possible for as long as possible. Just to set the stage here for our current standards of care for patients that are not getting surgery for HPV-positive cancers, Across the board, we tend to have survival rates at 5 years around 85% for HPV-positive tumors and 55% for HPV-negative tumors. And this will form the basis for a lot of the strategies that we'll be talking about following up here. On a side note, below we see the distant metastatic rates and the relapse rates. So along with the high survivals that we see here, we also want to maintain local control. And we can see that the HPV-positive tumors tend to have better local control and lower metastatic rates than those with HPV-negative tumors. Other principles that will pop up here coming on is treatments in patients with recurrent or metastatic disease. By recurrent and metastatic disease, we mean patients that no longer have any local modalities. For example, if someone has had previous surgery, oftentimes the next modality to go to is radiation or chemoradiotherapy, and then vice versa. However, if you have had surgery and chemoradiotherapy in a particular site, we generally cannot go into those modalities again. So we oftentimes tend to treat those patients very similar to patients with metastatic disease. Of those patients with metastatic disease, the most common site for metastases far and away is the lung, with bone being second. Traditionally, we've thought for all these patients, regardless whether they have recurrent or metastatic disease, the survivals have been measured in 6 to 10 month time frames. However, we're starting to get north of or higher than 12 months at this particular time, which is somewhat encouraging. Things to keep in mind is that patients often have had a lot of therapies and they tend to have poor performance status at baseline, so that provides challenges to all of us with regard to the toxicity that the patients might tolerate. And again, quality of life remains a major cornerstone through all of our conversations. So now we'll transition specifically into de-escalation. The premise for de-escalation is that HPV-positive tumors and other similar type tumors, those patients tend to have a very good prognosis. So the thought is that maybe we are giving them more therapy than they really need, and it's possible that we could de-escalate therapy and maintain the same amount of efficacy and then try to drop some of the toxicity, which oftentimes includes radiation-related toxicity, including problems with speech and swallowing that tend to be permanent for a lot of patients. The challenges, though, is that in HPV-positive tumors, they may have other comorbidities or other chemical exposures that we can't recognize via the tumor at this point with the information we know. So it's really a challenge, and so we'll go into some of these studies and the approaches to that. So in this slide, we're talking about the approaches for de-escalation and some of the ideas around that. So the first one is people oftentimes will try to switch out a particular chemotherapy and try to replace a chemotherapy or other agent that might have less toxicity. So in this particular slide, we're talking about taking out generally cisplatin and replacing it with the drug called cetuximab. We're talking about the differences in toxicities with regard to cisplatin and cetuximab. So cisplatin has many mechanisms of action, and it's been a drug that's been used for head and neck cancer for over 30 years. And many studies have been compared to cisplatin, and thus far cisplatin has always come out to be the most effective therapy. However, there's a lot of toxicities around cisplatin. Some of the major ones include increasing the risk of mucositis for patients undergoing radiation, dermatitis, enhancing the problems of dysphagia when they're getting radiation, increased risk of neutropenic fever compared to other agents. Other ones that we would include would be renal failure, hearing loss, sometimes permanent, and neuropathy. Cetuximab, as a targeted agent, has other issues that are different from cisplatin, such as acneiform rash, hypomagnesemia, and an infusion reaction. Once in a while, people can get anaphylactic reactions, so it's important to remember to make sure that this is discussed with the patients prior to therapy. There have been a lot of studies looking at cetuximab, and we'll focus on a couple of the major ones coming up right here. So on this slide, we show 4 studies that compared cetuximab versus cisplatin, generally in combination with radiation across the board. And there's been different ways to stratify these patients and different particular endpoints. So this is just a survey. A couple of the major ones we'll talk about will be the de-escalate trial and RTOG 1016. So on this slide, we have the phase 3 de-escalate trial. In this particular study, patients were eligible if they had tumors that are HPV positive, And that could be either with immunohistochemistry or in situ hybridization. It was focused only on oropharyngeal carcinomas. They had to have advanced disease where they would be generally eligible for chemotherapy and radiation. And of note, these were non-smokers or they had low amounts of smoking history. They were all given radiation. They were randomized to either getting a traditional cisplatin dosing of 100 milligrams per meter squared 3 weeks apart, or they were randomized to the other arm, which was cetuximab at standard doses weekly. Note here that the primary outcome was toxicity, which is different than many of our studies where we oftentimes have survival. Secondary outcomes were survival, quality of life, swallowing, and recurrence. So the primary outcome is where they power the analysis for. Keep that in mind. As we take a look, though, in the study, surprisingly, the 2-year overall survival in this particular population demonstrated that the survival was lower for the cetuximab group versus the cisplatin group, which was not particularly expected. In addition, the recurrence rates at 1 year and 2 year of the disease, while relatively low for both groups, was lower for the cisplatin group compared to the cetuximab group, which was also not expected. So it's thought that they would at least be equal across the board prior to the beginning of the study. What was also surprising is when you take a look at toxicities across the board and through their survey element, that the toxicity across the board regarding short-term late toxicities or overall was exactly the same across both drugs. Thus, the de-escalate trial was considered a negative trial with regard to the use of cetuximab versus cisplatin. So the conclusions were to not use cetuximab in place of cisplatin for most patients, even in the good prognosis area, because we were not able to meet those endpoints and thus would do the patients a disservice by putting them on cetuximab. On this next slide here, we have study RTOG 1016 or 1016, people often refer to it as. This is a very similar study to the de-escalates trial. They randomized patients who were eligible if they had HPV-positive tumors, but only by immunohistochemistry. As a side note, oftentimes people will design studies just for ease of eligibility to drop the modality technique complexities. So they use P16 positive immunohistochemistry only instead of using either PCR or in situ hybridization. These were oropharyngeal cancers. They were generally locally advanced. They were stratified by smoking but not restricted. So it was a bit more of a heterogeneous population because they had people that were heavy smokers and non-smokers all mixed in. And they basically randomized them to almost the same strategy with the cisplatin and cetuximab. However, the overall survival was the primary outcome, which changes some of the stats just a little bit. And then the other similar secondary outcomes were similar to the previous study. In this particular study, regarding efficacy, the overall survival rate, again, was higher for cisplatin versus cetuximab, and similar findings were found for progression-free survival. They presented their adverse events slightly differently than the previous study, but when we take a look across the board by looking at all adverse events and swallowing outcomes, they were very similar for both drugs. Thus, the conclusions from these prior two studies is that survival across the board is higher for cisplatin versus cetuximab. The rates of local regional recurrence or failure was higher for cetuximab versus cisplatin. They had very similar toxicities. Thus, these two studies, while important to be done, were unfortunately somewhat disappointing in that they failed to demonstrate that we could find a lower toxicity therapy with equal efficacy for head and neck cancers. So moving forward, there's a lot of strategies that people are trying to adopt in order to try to find different ways to see if we can help particular patients in these situations. So next we're going to be transitioning over to immunotherapy. As most people listening to this will be well aware of, immunotherapy has rapidly become a standard therapy in many, many cancers. And head and neck cancer is one cancer that, if we go back to our previous biomarker slide where we talked about the mutational rate per megabases, it was on the higher end. It's anticipated that patients who have tumors with higher mutational burden will be more responsive to immunotherapy. Thus, head and neck cancer, relatively early on, was recognized as a cancer where immunotherapy should be studied. So we'll be focusing on the most recent data, looking at the last study presented at the American Society of Clinical Oncology meeting in 2019, where they added immunotherapy. And we'll also be talking about immunotherapy down the road. But first, we'll be talking about some of the ancillary studies that we need to do ahead of time prior to determining who is eligible for immunotherapy, and some of the drugs and some of the potential targets for immunotherapy. So on this slide, we have a hypothetical T cell with a few of its different proteins that you would typically see that are associated with its immune function. Focusing on the circle, we would have this protein called PD-1. So T cells currently in most head and neck cancers and all cancers recognize cancers as being part of the body. And they do so via these particular proteins, such as CTLA-4 or PD-1 would be the ones that we most commonly think of. So PD-1 is on the T cell. Its partner protein that it recognizes would be on the cancer cell, in this case PD-L1. Thus, most of the studies thus far are focused on disrupting the interaction between PD-1 and PD-L1 in order to remove the recognition of the T cell for the cancer cell, activating the T cell to attack the cancer cell. The drugs that have been studied thus far that have made it into the clinic have been pembrolizumab and nivolumab for head and neck cancers. Other drugs that are being under studies for various cancers, and in many cases improved for other cancers, would be cemiplimab, specifically for squamous cell carcinomas of the skin, slightly different than the head and neck cancers. And then for other cancers would be the PD-L1 inhibitors. And the only difference is that the proteins are specific for that particular, the antibodies are specific for the particular proteins. One thing that has been recognized is PD-L1 expression quantification, and scoring is important for most of the tumors. In general, most of the studies have demonstrated that higher PD-L1 expression rates on the tumors is associated with increasing efficacy of the drug. Thus, if you have tumors that don't tend to express PD-L1, they oftentimes may have low rates of response or no response to the therapies, where higher expression of PD-L1 on the tumors generally have been associated with increased response rates. There's been a couple of different ways that people have demonstrated the amount of PD-L1 on the tumor cells. One is called the tumor proportion score. So what happens in these particular studies is that the tumor tissue is stained in a pathology lab with a stain against PD-L1, typical histochemistry staining, and they will then just particularly count the number of cells that have PD-L1 expression in a quantifiable fashion. The tumor proportion score is literally just the percent of tumor cells that have membranous PD-L1 expression. What's emerging is something called a combined positive score, where you take the number of PD-L1 positive cells, regardless of whether or not they are the tumor cells or not. So that would include tumor cells, the lymphocytes, macrophages, and then divide that by the total number of cells. PD-L1 is a protein that's on many different cells, not just the cancer cells. So it's thought that the total burden of the PD-L1 might play a bigger role than just having on a tumor cell. So you'll see moving forward in these studies that we're going to see some criteria is going to be the tumor proportion score, and some will be the combined positive score. That will be important mostly to talk about with your pathologist, because the pathologist will need to present you with the tumor proportion score or the combined positive score so that you can determine if a particular patient may be eligible for immunotherapy depending on the tumor type. So this is just a review again of the immunotherapy agents. Thus far, we're going to be focused on nivolumab and pembrolizumab. The other ones, while used for lots of other cancers, have not made their way into head and neck cancer treatment at this point. So now we're going to focus and switch over to immunotherapy in the first-line setting. Right now we're going to talk about the Keynote 048 study. This was presented at the American Society of Clinical Oncology. It's yet to be published, but it's been put out in abstract form, and is establishing itself as a go-to first-line therapy for patients with recurrent or metastatic disease. So the eligibility criteria for this study is that patients had to have head and neck cancer, and they had to have had recurrent disease, and they could not have had prior systemic therapy for any metastatic disease. In this case, when we go to the tumor proportion score, they had to have stratification on PD-L1 expression, but they didn't have a particular requirement for PD-L1 expression. and that was using the TPS, or the tumor proportion score. They didn't have a requirement for P16 positivity or negativity, but they did have to have that tested. And of note, they had to have an ECOG performance status of 0 or 1. One of the challenges is that many patients have an ECOG performance status of 2, so up front you can already tell that the designers of this study were worried about some of the toxicity in these patients, so they excluded patients with poor performance status. So they were randomized in a 1-to-1-to-1 fashion. So first arm, they were randomized to pembrolizumab by itself at standard dosing for up to 35 cycles, and the cycles are generally given once every 3 weeks. Arm 2 was pembrolizumab plus chemotherapy. A standard chemotherapy is either carboplatin or cisplatin plus 5-fluorouracil. They were given 6 cycles of this triple therapy combination, and then they were given pembrolizumab for up to 2 years afterwards. And the third arm was the current standard of care prior to the study, which was based on the study called the EXTREME study, and they were given cetuximab plus carbo or cisplatin plus 5-fluorouracil. The primary endpoints were overall and progression-free survival for the pembrolizumab chemotherapy arm versus the EXTREME arm in the population that had higher PD-L1 expression. In the study, while they stratified based off of the tumor proportion score, they also flipped and did initial analysis for the combined positive score. So one thing to keep in mind is that you see the tumor proportion score up front being listed, but then most of the analyses are done under the combined proportion score. So again, the combined proportion scores all of the cells, and so they pick cutoffs of 1 and 20. So in this particular slide, we see the overall survival in the left graph and for the higher proportion score, and the overall survival for those in the lower score. And we can see this was a comparison of patients that only received pembrolizumab versus those that received the EXTREME-based regimen. And for those patients that had the CPS of 20, we had higher overall survival by approximately 4 months that was statistically significant. This survival benefit also extends to patients with lower PD-L1 expression rates, albeit with lower benefit at 12 months versus 10 months, and the people with CPS scores at 1. Here we have the similar graphs, only for progression-free survival. For both PD-L1 expression levels, we see that despite the fact that overall survival is higher for the pembrolizumab group, regardless of PD-L1 expression, we don't see the similar findings for progression-free survival. Thus, there's something else going on with these patients with regard to benefits. They're living longer, but it's not necessarily all related to the progression-free survival, which is something that we do oftentimes see for immunotherapy. If we take a look at the response rates, they tend to be what we oftentimes see for many immunotherapy groups. We see higher response rates in the chemotherapy group, which would be the EXTREME group, which is to be anticipated, but those higher response rates up front don't turn into longer-term benefits overall. So the next set of analyses, we will focus on the pembrolizumab chemotherapy group versus the EXTREME group, looking at the patients that had tumors with greater than 20% expression versus 1% expression. The overall survival for these particular patients, again, was higher for the pembrolizumab-based chemo group versus the EXTREME group by about 3.7 months, but had very similar progression-free survival benefits across the board in both the group greater than 20% and the group at 1%. So to recap, if we take a look across the board, as a final, we take a look at the pembrolizumab versus the chemo groups. We have higher overall survival rates across the board for all of these, no matter what regimen is versus EXTREME. So pembrolizumab or pembrolizumab plus chemotherapy is superior to the EXTREME group. On the next slide here, we're taking a look at the adverse event rates, though, which is important. If we take a look at the adverse event rates or the toxicity overall, as expected, they're lowest at 54% for pembrolizumab, but it does not get higher for the pembrolizumab chemotherapy group versus the EXTREME group. If we take a look at adverse events that lead to stopping therapy, it's 12% for pembrolizumab, and the 32% for the pembrolizumab and chemotherapy versus the 27.5% for the EXTREME group is very similar. So overall, based on this, you can see that the FDA approved pembrolizumab for first-line therapy for patients with metastatic or unresectable recurrent head and neck cancer. They approved pembrolizumab in combination with a platinum, which would be cisplatin or carboplatin, and fluorouracil. They also did approve it separately for patients whose tumors express PD-L1 greater than 1 based on the proportion score. And generally speaking, it's recommended that you would use the PD-L1 immunohistochemistry stain as designated by the FDA if at all possible. So right now, I would consider that an emerging standard of care would be pembrolizumab plus a platinum plus 5-fluorouracil for patients with head and neck cancer that are in the recurrent or metastatic setting, and consider pembrolizumab for those patients alone that have more problematic toxicities in those patients that have a CPS score greater than 1. In this next slide, we're just going to summarize just a few similar studies that are going on that we're waiting for results to come through on. So these have included chemotherapy only. So say, for example, nivolumab plus ipilimumab versus the extreme regimen. We've also got a similar study for durvalumab plus tremelimumab. Of note, just as a reminder, nivolumab and durvalumab are the PD-L1 agents, and ipilimumab and tremelimumab are CTLA-4 antibodies. Down below, we see some other studies where we're adding pembrolizumab to chemotherapy and radiation to see if that will help in the metastatic setting as well. So here, we're just going to follow up with the studies that have been out there in the second-line setting already. So at this point, a lot of providers may have patients that have already been treated with chemotherapy, either via the extreme regimen or oftentimes with carboplatin and Taxol, maybe carboplatin or cisplatin and 5-fluorouracil, maybe single agent. And there will still be a place for immunotherapy to be given after they have seen previous systemic therapy. So there have been some studies that have been done with just single-agent immunotherapy in the second-line setting after people have already had chemotherapy. These studies have been nivolumab and pembrolizumab predominantly as the treatment modalities of choice. Nivolumab was previously approved based off of a randomized phase 3 trial comparing single standard agent chemotherapy versus nivolumab by itself with overall survival benefits. And the similar thing was done for pembrolizumab. Okay, so now we'll transition into the phase 3 Checkmate 141 study after we've gone over our summary here. Nivolumab was compared to investigator's choice of methotrexate, docetaxel, or cetuximab in patients with recurrent or metastatic chemotherapy. While the overall survival benefits were statistically significant, they were modest, with an improvement of survival of 2.6 months for the nivolumab group. When compared across the board for PD-L1 expression, the benefits were higher for those that had greater than 1% PD-L1 expression, and for those that had less than 1% expression, the benefits dropped off somewhat, although trended towards significance but not quite there. When we stratify based on HPV status, the survival benefits are higher for the HPV-positive tumors and maintain statistical significance with a 4.7-month benefit. The benefits drop down to a 1.2-month benefit, but still statistically significant for HPV-negative tumors. The side effect profiles for nivolumab was quite typical for single-agent immunotherapy, and the overall adverse events were lower in the nivolumab arm versus chemotherapy arm. Thus, nivolumab has been approved by the FDA for use in the second-line setting. For Keynote 040, this was a very similar study to the previous one. This was pembrolizumab versus investigator's choice of chemotherapy, very similar to the previous study. In this particular study, pembrolizumab was associated with a slightly higher overall survival of 1.5 months versus the standard of care. When you take a look at the CPS, or the combined positive score, which is slightly different than the previous study, higher PD-L1 expression was associated with a higher overall survival rate. And when we increased the PD-L1 expression sample, the overall survival rate goes up a little bit more. So the higher the PD-L1 expression, the higher the overall survival benefits that we tend to see. Adverse related events, very similar to other previous studies. One thing to note in the pembrolizumab based study here for Keynote 040 was that hypothyroidism was a little bit higher than we had seen previously, possibly. And so it's something to keep in mind. So in summary, if we take a look at immunotherapy-based studies that are now FDA approved, we've got the Checkmate 141 that supports the use of nivolumab. We've got the Keynote 040 that supports the use of pembrolizumab all in the second-line setting. And we've got the Keynote 048 study that led to FDA approval up front this past year. Just as a heads up, these studies are probably just the tip of the iceberg. The strategy right now is to take a PD-1 or PD-L1 antibody and mix it with another particular agent. And there's a lot of different possibilities in seeing if there can be synergistic benefits by adding immunotherapy with another particular agent that will target a particular pathway. So there are varying pathways or other strategies that are being done. Example, we've already seen that there are studies looking at adding it to a CTLA-4 antibody, such as you would see in kidney cancer or melanoma. Other things could be other immunomodulators, such as OX40, KIR. KIR is, you may have heard a few in the transplant world. Other vaccines or even chimeric antigen receptor therapies, mixing with radiation, and then a whole slew of different targets, such as MEK inhibitors, TGF inhibitors, etc. So that concludes our overview of what we think is the kind of important elements of the state of head and neck cancer: diagnosis, risk stratification, and treatment. In our conclusions right now, we just want to leave you with the following thoughts. Overall, we went over the epidemiology and demonstrated the current epidemiology, and also demonstrated that the data that supports that veterans have unique challenges with regard to the biology of head and neck cancer, the toxicity, and the challenges with treatment delivery and survivorship care. We presented data supporting the ongoing research for precision oncology-based treatments in head and neck cancer, and there certainly remains a very large amount of work to be done in this particular area. We discussed HPV status as a area to use for prognosis, risk stratification, and strategies for de-escalation. Right now, it would be our conclusion that de-escalation or de-intensification of therapy, while certainly an important area of research, has not yet been demonstrated to be a standard of care. Most places would not consider de-escalation or de-intensification outside of unique clinical situations. Combined immunotherapy and chemotherapy is now emerging as a standard of care in recurrent head and neck cancer and metastatic head and neck cancer. And we ask that you stay tuned for a lot of studies coming down the pike. It should be an exciting time for head and neck cancer treatment, and hopefully we'll have lots of positive results to talk about in the near future. Thank you for your time.